we'll move on to the next speaker, and I'd like to introduce a friend of mine, Professor Ji, who's the professor and director of the Department of Medical Ultrasonics at the first affiliated hospital in Sun Yat-sen University in Guangzhou in China. And we're going to have Professor Ji talk to us about the intracavitary contrast-enhanced ultrasound in clinical practice, a relatively unexplored but exciting area for the use of contrast. Professor Ji.
Hello. Dear Professor Xidou and Professor Ping Liang, ladies and gentlemen, welcome to the web class. Today, my topic is about the intracavity contrast enhanced ultrasound for about the innovation and the clinical application. I'm Dr. Xie. I'm from Guangzhou, China, Sun Yat-sen University. And today I will cover the bile duct, gallbladder, and the urinary system and the gastroenterology. Just like we know, the contrast ultrasound in the bile duct, we can see, we can make a beautiful image, just similar to the X-ray image in the bile duct system. I don't like to talk much about the bile duct. Today, I will start from the gallbladder. So I'm focused on in the percutaneous ultrasound guidance contrast cystography. I called it PASC. It's used to earlier exclusion of the biliary atresia in infants. In our study, we included about 14 cases, but today I'd like to present the very first nine cases. The babies is about 16 days, and we use the interventional ultrasound and the general anesthesia. Use the linear transducer, and then we puncture the gallbladder. Use the 18-gauge PTCD needle, and then we injection some dilated soluble liquid into the gallbladder. So we make the diagnosis in the criteria if the patients without biliary atresia, the contrast agents will visible in the gallbladder, common bile duct, and the common hepatic duct, and the duodenum. If the patient with biliary atresia, its gallbladder is visible only, but cannot see the common bile duct. So in our research, we can see the two types in the baby. One is only see the gallbladder, another kind is gallbladder and compactor bile duct, both visible. So we can see the first case. This case is the normal gallbladder and bile duct. It's 28 days baby. We can see the gallbladder in 2D, and we cannot see the bile duct, maybe suspicious for the biliary atresia. Then we use the contrast ultrasound to puncture the gallbladder, so we can see the gallbladder is visible, is fitting by the contrast agent, and the common hepatic duct and the common bile duct and the duodenum is filling with the contrast agent. So the baby is exclusion with the BA. But in this baby, the baby is suffer from the biliary atresia, so we can use the contrast agent to puncture the gallbladder, and we only see the gallbladder. We cannot see the common bile duct and the duodenal image in these cases. So we can say the advantage of the PASC the first one is the less invasive. We can compare with the intraoperative colonoscopy, and then the PASC is more reliable. Is compared with the 2D ultrasound, and then we can use the PASCs to help the baby to relieve the cholecystitis and in the infant without BA. And the very important things is use the PASC. Is no radiation. It's very helpful for the baby. So in conclusion, PASC is a safety effective tool to early exclusion BA in infants and who are clinical suspect of BA but without image improvements. And the PASC is help to avoid unnecessary laparoscopic colonoscopy. This is our paper in the radiology. And next, I'd like to move to the urinary system. Focus on in the contrast the enhanced ultrasound assistant techniques, nephrostomy, PNS. The technique is to increase the success rate for the patients with no dilatation renal collection system. Just a nice these pictures. As we know, if the patient with the hydronephrosis, it's easy to implant the tuber and to make the drainage. But if the patients have no hydronephrosis, it's difficult to do that. But sometimes the PNC is necessary. For example, the complete renal stone or the upper urinary injury or post-operative urinary leakage or fistula, or is the chronic renal failure. So how to do? We just firstly we like to find the renal pelvis. We have 47 patients and 48 kidneys. Firstly, we try to find the renal pelvis, maybe very small. So and then we make a puncture test. Use the PTCD needle to puncture, and we injecting some contrast agents to confer. When we confer, the needle is in the renal pelvis. We'll have a enhancement or angiograph in the graph in the pelvic system. Then, according to the contrast ultrasound, we can position the catheter, and so it make the process is very easy. In this case, we can see we just use the contrast ultrasound to confirm. Here is the needle, here is the renal pelvis, and next patient we can see the needle here and the enhancement in the renal pelvis. So sometimes we can see the urine tract in the patients. So in our research, the technical success rate is 100% in 47 cases and 48 kidneys. And the mean needle punctures is only 1.4. It's very precise. And one puncture in 13 cases, and the two patients have 17. But one patient is very overweight and post-operative urinary leakage. We have punctured 3 times. And the third one is minor complication. Only 4 patients have the minor complication. One with renal hematoma. And so we can say the advantage of the contrast ultrasound PNS is no radiation, easy to evaluate, and high successful rate, and more information compared with the bead mode ultrasound, and have real time and real-time and refreshed multiple scan compared with the X-ray. X-ray only one time injection. Because the successful rate is 100%. Now I'd like to move. I will focus on the intracavity contrast enhancement for detecting the fistula in the Crohn's disease. As we know, the Crohn's disease is a green tumor. It usually happens in the young group and with long history and hard to treatments. So the fistula is occurred about 20 to 14 cases. The patient is needed to operation treatments, but the key to detection the fistula is very important to make the decision for the surgery operation. But it's very difficult to discover the fistula. Usually, we recommend the CT and the MRI as the first way to detecting the fistula. But in some meditation, radiation and high cost and no diagnosis accuracy is about 20 to 16%, and is useful in the typical fistula, but it's failure in the complex and the complex fistulas. Just like this picture, it's maybe it's difficult to say where is the fistula. How to do in the ultrasound? We like to do some abscess injection. For this picture, we can see the intestine wall is very thick and some abscess is around the intestine. Then we injection some soluble in the abscess cavity. If the cavity is have a tunnel connecting with the intestine, it's a fistula. If have no connecting, cannot find the tunnel, it's just a simple abscess. So the drainage is enough. So in our study, it's the procedure is firstly we use a needle to suction and to puncture the abscess and suction the abscess. Here is the abscess suction things, and then we injection the dilated contrast agent soluble into the abscess cavity. So you can see with the falling of contrast agents, the anatomy of fistula tunnel between the cavity and the bowel and other organs can be clearly seen and directly. Just this picture. Here is the puncture needle. Here is the abscess cavity. By injection by following of the contrast agent, we can see the fistula and the intestinal enhancement, and some contrast agent follow in to the blood. In our study, we have gathered 31 fistula patients, and the fistula was confirmed by surgery operation and the operation samples. So in our research, the patient's fistula, 20-page fistula is just the intestinal and the peritoneal cavity. In 11 cases have intestinal and blood cavity, but in the 2 ultrasound and the contrast ultrasound, only 2 cases detected. By the intracavity contrast ultrasound, we detected the 26 cases, and the fistula diameter is about 2.8, and the fistula length is 1 centimeter, 1.6 centimeter. We use the contrast agents. The quality is about 2 to 22 millimeter with no side effect and no complication. Here is the detail about the detecting of the fistula. You can see the IC contrast ultrasound is 86.7% to detect the fistula, but the CT and MRI is about 15%. It's about twice double than the CT and MRI. And here is our first case. It's the intestinal-bladder fistula. It's 19 cases. Here is the abscess, but by the MRI, we can see adhesion between the intestine and the blood, but we cannot see the fistula. When we injection the contrast agents to the abscess, we can see that the agents follow in to the intestine, and another way follow in to the blood. We can see here is the fistula. The second case is also the intestine-bladder fistula. It's a 15 years old cases. The patients have a clinical symptom of urine infection and positive urine culture, bacterial culture for 2 months, but the fistula cannot detect him by endoscopy, by CT angiography, and by retrograde urethral injection cystography. So here is the MR scan and CT scan, and here is the cystography. It's negative. Here's the blood. So when we injection the contrast agency to the abscess, we can see the fistula and the bubble line over the urine in the blood. And here is the fistula. It's very clear. It's very clear. So here is the video for this patient. Here's injection, fistula, and here is the blood. So, okay, we can see the bubble in the blood. Okay, let's move to next slide. So after the operation, during the operation we can see adhesion of the bladder and the intestinal. And here is the fistula orifice. It's in here, and so we can make conclusion the intracavity contrast ultrasound is a new and effective diagnosis modality with much high detecting the rate of the fistula than CT and MI, and no radiation and low and lower cost. And maybe we can should be maybe should be an imaging standard for diagnosis the fistula before the surgery. So you can say the intracavity contrast ultrasound is a new resolution for the challenging clinical issues. So I like to say bubbles, imaging bubbles, bubbling beyond the imaginations. Thank you. So thank you. It's my presentation. Thank you very much.
Professor Ping Liang to return to online. First question I have is from Shaw, who says, how can we simplify the process to assess lesions with 3D CEUS? Professor Ji, can you simplify the 3D examination?
Yeah, I just use the 3D probe to maybe we must to have a 2D in contrast ultrasound for the fistula firstly, and then we use the 3D to take the data by 3D probe. It's easy to reconstruction the 3D image.
Okay, but Professor Liang, this is a question for you as well. Have you any tricks or tips for improving 3D?
Yes, but only a few cases use the 3D to evaluate the therapeutic effect after thermal ablation. A few cases, not so much experience.
Yeah. I mean, the technology is still not quite sufficient to make it easy to use yet, is the answer. We can do the scanning, but the scanning is not easy. I got another question here for how PUSCC is relieving cholecystitis. from Shamrain. How can you relieve the cholecystitis? Can you use it to help at all? I think we'll skip to the next question then. How much contrast do you use for gallbladder injection? What percentage of dilution?
To me?
Yes, to you. What's the dilution?
Okay. I used to the 201% or 301% for the original liquid to dilution the contrast agents is enough. If too much contrast agents, maybe some shadow, is difficult to see the bioduct posterior wall. Yeah.
I agree with you. We use 0.1 mil dilute to 20 or 50 mils of saline. You get perfect imaging. Perfect imaging.
Yeah.
Okay, well, I've got another question here. How long does it stay visible in the cavity?
You mean the contrast agent?
Yeah. How long will it stay?
It's more than 6 millions, because just stay in there maybe 10 minutes or more longer. Maybe just it's different from in the vessel. So if I like to injection again, I must to use the flash to destroy the bubble. Yeah. So I think it's very superficial to the X-ray. X-ray you cannot flash just a one-time injection. But use the contrast ultrasound, we can injection many times.
Exactly. And we're using the flash, which is busting the bubbles. You don't have any reaccumulation from blood flow, so you can then re-inject. So it's a beautiful technique. Let me see if there's another question. We have another question on dilution. I think we've covered that. And someone saying, both of you, excellent presentations. Well done. And I think that's all the questions we have.